tumor. This is the main core of our case 4. Okay. So what is our ILOs for this lecture? This is like you must know the terminologies. What do you mean by polyp? What is adenoma? And what is their pathological features of the adenoma? Then like what are the risk factors of colorectal carcinoma, especially our lifestyle, how our lifestyle can affect our colon mucosa to go into the neoplastic transformation. Then genetic basis of the colorectal carcinoma, like we need to see the what is adenoma carcinoma sequence. Okay. Then how do you differentiate between sporadic and inherited cancers? Then knowledge of the malignant tumor, different types of tumors of the colorectal carcinoma, the features of benign and malignant tumors of the colon. Okay. So what do you mean by polyp? A polyp or a polypoid lesion are the inflammatory masses or tumors arises from the submucosa or muscle coat but protruding into the lumen. Okay. So it is the projection, a finger-like projection of mucosa, submucosa, or muscle coat that protrude or that hangs into the lumen, or that it can be seen as an elevated lesion in the lumen. The polyp could be inflammatory or could be neoplastic. Okay. Polyposis, what do you mean by polyposis? Polyposis means multiple polyps. Polyposis syndrome is hereditary. Whenever you call it is a polyposis syndrome, it is always hereditary, characterized by presence of multiple pedunculated. What do you mean by pedunculated? A polyp which has a stalk or which has a connection, which is more elongated, a stalk like a tree. You have the bark of a tree and the leaves. Okay, so it has a stalk and the sessile, which is just a flat elevation like a stone kept in a pipe. Okay, it's just a flat elevation and it can be benign or malignant. Okay. So polyposis syndrome, polyposis, and a polyp. Okay. So what are the different types of the colonic polyps? Okay. We have non-neoplastic polyp. Okay. What do you mean by non-neoplastic? These polyps, they don't have a tendency to the malignant transformation of the same polyp to go into the carcinoma. Okay. The same polyp. What is this non-neoplastic polyp? Polyp are the hyperplastic, inflammatory, juvenile, and Peutz-Jeghers syndrome. Okay. As we discussed last class, Peutz-Jeghers syndrome is a hereditary cancer syndrome. This causes cancer of different organs. Okay. But does not cause a cancer of the polyp of a colon. Okay. In that case, the associated polyp is a Peutz-Jeghers polyp. Okay. Or it is like what you call it is a type of a hyperplastic polyp. We can say it's like a Peutz-Jeghers polyp. Okay. So these are the non-neoplastic polyp. Peutz-Jeghers is a hereditary cancer syndrome, but a polyp in a colon is non-neoplastic. Okay. Neoplastic polyp can be benign or can be malignant. It can be arising from epithelium, adenoma. It can be carcinomatous polyp, carcinoma, or it can be other tumor like lymphoma of a GIT, which can also have a polypoidal projection into the lumen of the GIT, just gastrointestinal stromal tumor or other tumors can have a polypoidal projection into the thing. So if you have been asked, mention two non-neoplastic polyp or mention three neoplastic polyp, adenoma, adenocarcinoma, lymphoma, GIST. Okay, this would be your thing. Okay, so we are going to talk about two different type of polyps, non-neoplastic polyp, which are common, and this is hyperplastic polyp and the Peutz-Jeghers polyp. Hyperplastic polyp, its name slip, it is just a hyperplasia of the normal colonic mucosa. Okay, this there is just normal hyperplasia. They get a finger-like projection into the lumen. Okay, they are most of the time asymptomatic. They are majority of them are located in the rectosigmoid and 20% of them you can see in the ascending colon. Okay, they are smooth, they are moist, they are round, small, 0.5 centimeter, and most of the time they are sessile, not the pedunculated one. Can be seen multiple polyps with the hyperplastic polyp, and under the microscopy you see the well formed glands and crypts lined by differentiated goblet or absorptive cells. Okay, so they are normal, absolutely normal, just only they are more in number. Okay, and they don't have any malignant potential. Okay, pure hyperplastic polyp, they don't have malignant potential. Okay, they are just like small polyp. They are asymptomatic, but sometimes they may have symptoms of altered bowel habits, and sometimes they might have bleeding per rectum. Okay, the Peutz Jaeger polyps, they are hamartomatous polyp, means there is abnormal accumulation of the abnormal tissues. Okay, they, like, it is a syndrome. You know, this is a Peutz Jaeger is a syndrome. It is a hereditary tumor, so they can be accompanied. They are accompanied by mucosal and cutaneous pigmentation. The patient will have pigmented mucosa of the conjunctiva, pigmented mucosa of the tongue, or they can see the pigmentation around the lip, okay, or face, pigmentation or the face, or pigmentation around the genitalia. This is one of the very important feature to diagnose. You have a long scenario, and just only with one thing you can pick the diagnosis: pigmentation around the mouth, genitalia, and the mucosa. They are rare, but and their way of transmission is autosomal dominant. They are caused by germline mutation in the LKB1 gene, which encodes a serine threonine kinase. Okay, their polyps are large, they are pedunculated, they occur anywhere in the GI from esophagus to the rectum. Okay, and they have an increased risk of developing carcinoma of the pancreas, breast, lung, ovary, and uterus, but not itself in this polyp. Okay, that's why they comes into the non-neoplastic polyp. Now we go to the neoplastic polyp. So this can be benign or can be malignant. Benign one is the adenomas or adenomatous polyp. They are usually commonly seen in the large bowel. They can be seen 20 to 30% before the age of 40, and as we grow old, their incidence also increases. 50% can be seen in the age of 40. Males are more commonly affected than the female. Oh, sorry, males and females are equally affected in this. There is no sex prediction over here. They can be seen as a sporadic. They can be have in the familial presentation also. They can be a small, large, single, multiple, pedunculated, or sessile. And these are the results. This is neoplastic one. So there is definitely epithelial proliferation, dysplasia, which may range from mild to severe dysplasia, and they can also undergo to the carcinomatous changes. They can transform into the carcinoma. They are divided into their histological features: tubular adenoma, where you see the more of the tubular glands, less of the villus architecture; villus adenoma, where you see the villus architecture in the more than 50% of this adenoma; and tubulovillus is the combination of both. So we go for the tubular adenoma. That's the most common type of adenoma. 70% of the all neoplastic polyp are the tubular adenoma. It occurs sporadically as well as in the well-defined hereditary syndromes like HNPCs. As you see our case, we found 3 tubular adenoma and the 1 large carcinoma. Okay. Average age is around 60 years. 75% occur in the distal colon and rectum, like rectosigmoid, sigmoid colon, or the descending colon. They are, if they are like purely tubular adenoma, they usually see seen in the single, and their size can be few millimeter to the centimeter. They can be sessile, they can be pedunculated. Okay. And when they are pedunculated, their stalk will have a central core of the fibrovascular tissue, and it's lined by the normal or dysplastic colonic epithelium. They can also have the severe dysplasia and the invasive carcinoma. Just I'm sorry, I just got a call. Okay, so these are about the tubular adenoma. They can see the dysplasia. This dysplasia can range from mild to moderate to severe, and they can have also tendency to invade and become an invasive carcinoma. Then we go to the villus. Okay, villus adenoma. They are least common as compared to the tubular adenoma. They are like usually largest and like very large. Like if you see as compared to tubular adenoma, they are larger than the tubular adenoma. They usually seen in elderly age, male, female equally, and they have like symptoms, symptomatic. They have like um, anemia due to rectal bleeding, and sometimes you have like they have like mucoid diarrhea, so like they are like copious amount of stool rich in mucus. Okay, and again their location most commonly in the distal colon, like your rectosigmoid area. As I told, they are larger in size. They can be up to grow up to 10 centimeter in size. They are broad. They are most of the time sessile, velvety because of multiple villus on the surface. They look like velvety. Okay. And microscopy, you see the aggregates of villus architecture or hyperplasia of the villus with dysplastic cells. And you have like all degree of dysplasia, and some you have when you see a villus adenoma, you have to carefully look for the invasion, because the invasion can be seen up to 40% of the cases. Then we have tubulovillus adenoma. It has features of combination of both. Now it is very very important, as a pathologist or as a treating surgeon, you must know whether the what polyp you are seeing over here, it could be a benign or malignant. Okay, an adenoma to carcinoma sequence is a documented sequence, and it is the one of the prototype example of the multi-step carcinogenesis. So you should not stop just diagnosis with the adenoma. You must carefully look for whether it is a single adenoma, whether they are multiple. If they are multiple, whether it is association of a syndrome, whether there is a dysplasia, what is the level of dysplasia, whether it is mild or severe. If it is severe, whether there is an invasion is present or not. This is all you have to look carefully. Okay. So when you see a polyp, what is the probability of the carcinoma? One of the most important is the size. Uh, During the colonoscopy, a surgeon can identify, can predict it is a benign or malignant on the basis of the size. Larger the size, more chances of the it turning out to be a malignant. Some book reference has says 2 centimeter. If it is less than 2 centimeter, mostly benign. If it is more than 2 centimeter, mostly malignant. So size is the most important criteria. Then another important criteria is villus architecture. More villus architecture on the histopathological examination, more chances it's turning out to be malignant. Then cytological atopia or dysplasia. More severe the dysplasia, more chances of the it is going into the this thing. Okay, you can be asked like about a question, the probability of the where like mention 3 features of a polyp which can help to see whether it is malignant or problem, or mention probability of the neoplastic polyp. Okay, so size of the polyp, villus architecture, and the dysplasia. These are the 3 features, very, very important. And among these 3, the size is very, very important. Or you can have the most of the, which one of the following is the most important denominator of malignancy in a polyp or in an adenoma? Size, tubular architecture, mild dysplasia, or something. Okay, so size will be most important. As I told, this polyp can occur in the single or can be seen in the syndrome. Okay, so you have the familial polyposis coli syndrome, where you see innumerable, like, to diagnose a familial polyposis coli syndrome, you must have 100, minimum 100 neoplasm, but they can be in the thousands. Okay, polyps can also be seen not in the colon, they can be seen from esophagus to the colon, but commonly in the colon. And most of the time they are tubular adenoma. Gardner syndrome, you have polyposis coli. Along with that, you don't have the malignant transformation along with the in this coli, but you have like multiple osteomas, epidermal cyst, and fibromatosis. Turcot syndrome, you have polyposis coli, colorectal carcinoma, glioma, and fibromatosis. So these are the familial polyposis syndrome. Other one is you have hereditary non-polyposis, where you have polyp but they are not in many number. That's why we call it them non-polyposis. So to discuss one very important FAP, it is the autosomal dominant disorder. It is genetic defects on the short arm of the chromosome 5, band 21. Okay, so located on the chromosome 5. Patient developed hundreds of colon adenoma as during his teenager life also. Affected gene is name itself APC gene, adenomatous polyposis coli gene, located on the chromosome 5. You need to have at least 100 polyps to diagnose is a FAP. Histologically, they are usually tubular adenoma, and colorectal carcinoma develop in 100% of the cases. Okay, and even before the age of 30. And when you diagnose this patient in a earlier age, prophylactic colectomy is the standard therapy. You ask your patient, if you have to prevent to develop carcinoma, undergo removal of entire colon. But to diagnose 100 of minimum 100 polyps are required, and they must have tubular architecture. Okay. Neoplastic polyp, we discuss about the colorectal carcinoma. Now the epidemiology. Colorectal carcinoma is responsible nearly 10% of the all cancer death worldwide. It's the third leading cancer in men and the second leading cancer in women throughout the world. Okay. First, third leading in the men, and the second leading in the women. Colorectal cancer is the second most common cancer after breast cancer in the generals of the population. Okay. If you look generals of the population, most common cancer, forget about the sex, most common cancer in the generals of the is breast. Second most is the colon. And both of these cancers are related with the diet. Okay. You see, due to westernization, our diet has changed totally. We don't eat our normal diet of the region. We generally follow the change of diet will lead to the shift into the epithelial response, and that can lead to the development of the cancer. Coming to the Medina region, CRC is the number one cancer in the men and the third most common cancer in the women after breast and thyroid cancer. See, in our region where we are residing, CRC has become the most common cancer in the men. And the age is 60 to 70 years of the age. Our patient Fahad also was 65 years old. Okay. And usually when it is sporadic, less than 20% of the cases see before the age of 50. But if it is a family, you can see as early as between the 30s and 40s. Not the risk factor. The dietary factor is the most closely associated with the increased colorectal cancer rates. Okay. And why? Which are the dietary factor? Low intake of unabsorbable vegetable fibers, like low fiber diet and high intake of refined carbohydrates and fat. So from where we get the high intake of refined carbohydrates and fat from your like breads, pizzas, your fries, your pastries, your ice creams, your pastas, what you eat daily. Okay. and you don't take the vegetable, the normal vegetable, which is usually consumed at home. We usually don't take, we go for the refined fiber. Okay. So how does it affect? Because of the reduced fiber content, you don't have the fiber contents into the your diet, that lead to the decrease in the stool bulk formation. When the stool bulk formation is not there, it will also alter the composition of the intestinal microbiota. So fiber will not, one thing, they will alter the normal microbiota of the colon or intestinal microbiota, GIT microbiota. And second, they have reduced bulk of the stool. So stool, higher the bulk of the stool, that will lead to the increased motility and increased passage of the stool. When there is a reduced bulk, the stool with these toxic nutrients which we have got it from this high refined carbohydrates and fat will stay for a longer period of time into the colon, and that will lead to the synthesis of the potential toxic oxidative byproduct of the bacterial metabolism. And they also need to the hepatic and synthesis of cholesterol and bile acid, which can convert into the carcinogens by intestinal bacteria. All put together will increase the time duration of exposure of this material to the intestinal mucosa, and that will lead to the cell injury and alteration, and that will lead to a cell to go into the neoplastic transformation. Another risk factor, family history of CRC. If someone has colorectal carcinoma, ovaries, endometrium, and breast in women, they have high incidence of colorectal carcinoma. Genetic factor, as we already discussed, FAC, FAPC, HNPCC, we'll discuss in the coming slides. History of diabetes, hypertension, and obesity. This also is closely related with the dietary intake. Okay, those have abnormal diet, they have diabetes, hypertension, and obesity, and it will in turn lead to the increased CRC risk. Someone suffering from inflammatory bowel disease, especially the ulcerative colitis, high risk of colorectal carcinoma. A history of radiation therapy for prostate cancer or any other intra-abdominal cancer, exposure to radiation will lead to the increase. There is one mechanism is there, COX-2. This is the enzyme which like converts to prostaglandin E2. This prostaglandin E2 promotes epithelial proliferation. If you use the COX-2 inhibitors, especially the drugs, aspirin and other NSAIDs, which are COX-2 inhibitor, they have protective effect. So someone who has at the increased risk of colorectal carcinoma, we might start them with the low dose of aspirin as the inhibitor of COX-2 inhibitor, so that prostaglandin E2 should not be formed in the gut and epithelial proliferation can be stopped. So these are all the causative effect, and this aspirin and NSAIDs have the protective effect. Clear? Is it
Yes,
clear
doctor.
for you all or not?
Yes, it is.
You are now you can understand in a better way about the risk factors of the colorectal carcinomas. Okay.
Okay.
Now the molecular pathogenesis. So these are all the risk factor ultimately leading to the genetic alteration. There are the two molecular pathogenetic mechanism of the colorectal carcinoma. One is the adenoma carcinoma sequence. Another one is the microsatellite instability. So go for the adenoma carcinoma sequence. Between 70 to 90% of the colorectal carcinoma arise from adenomatous polyp. Okay, first they have a adenoma, then this adenoma will go dysplasia and they go into the carcinoma. The adenoma carcinoma is a multi-step progress. Okay, and it has involvement of various genes, okay, like mutation, deletion, tumor suppressor gene, oncogenes, the signal transduction genes, the angiogenetic mechanism, the gene leading to the invasion, all these things go. Polyps, as we already told, polyps with the tubular histology pattern have least malignant potential, while the villus adenomatous polyp have highest malignant potential. The larger the polyp, more than 2 centimeter, the greater the size has the most important, followed by the histological pattern, which we already discussed earlier. So what happened over there in the adenoma carcinoma chances? Okay, first there is normal epithelium. Normal epithelium goes into the hyperproliferative or hyperplastic epithelium. Early adenoma, intermediate adenoma, late adenoma with dysplasia, or we can say adenoma with moderate dysplasia, mild dysplasia, moderate dysplasia, severe dysplasia, carcinoma. And what happened over here? There is loss or mutation of APC gene. Okay, loss of DNA repair or DNA methylation gene, mutation of the RAS gene on the chromosome 12p, tumor suppressor gene loss, especially p53 gene or other tumor suppressor gene, loss of p53 gene on the chromosome 17p. This is all multi-step mechanism at the level of epithelium and at the level of molecular, will lead to development of from a normal epithelium to a carcinomatous epithelium. So mucosa, this is the normal colon. Okay, so mucosa at the risk when you have got the germline mucosum as an inherited mutation in the APC gene, or you have, like, this is the first hit. Okay, then there is methylation abnormality or inactivation of the abnormal allele, like loss of APC gene in the both beta through the beta catenin. Okay, so there is hyperplasia. There is various proto-oncogene mutation, especially the oncogene KRAS activation, development of an adenoma. Then there is a loss of p53. So normal type of wild type of p53, oncogene induced adenoma sequence. This adenoma go sequentially changes in the mild to moderate dysplasia, where also here loss of p53 gene will lead to development of the carcinoma. So this is the multi-step carcinoma at the epithelial level, at the molecular level. Now the second mechanism is the microsatellite instability. What is microsatellite? This is like they are the molecular signature of the defective DNA mismatch repair. Okay, the microsatellite send the molecular signals so that there is, whenever there is a defect in the DNA, and these microsatellite, when the signals go to the genes come and they repair the DNA. When there is an instability in the microsatellite, there will be a defective DNA repair. Okay. And the mutation in the colorectal carcinoma are the gene are the MSH2 and MLHL are found in the sporadic carcinoma, and MSI in the familial HNPCC. Okay, so these are all the DNA repair gene, but MSH2, MLH1 in the sporadic cancer, while MSI with microsatellite instability with the MLH2 and microsatellite instability with the HNPCC. So in both sporadic as well as inherited, you find the microsatellite instability and involvement of MSH2, MLSH1. So 90, 80 to 85 to 90% of the sporadic cancer due to involvement of the APC gene. 10 to 15 of the sporadic cases due to involvement of the DNA mismatch repair gene. Okay. So these DNA mismatch repair gene, there is the defective DNA repair. Okay. And this defective DNA repair, DNA is not repaired properly. The defected DNA has gone into the cell cycle and there is development of the gene. Okay. So you have MSH2, MSH6, MLH1. These are the very, very important gene, especially MLH1, which is one of the most commonly involved in the sporadic colon cancer. So this is MMR pathway or mismatch repair gene pathway or microsatellite pathway. There is a normal cone, normal mucosa, mutation in the repair gene, MHH2, MLH1. There is like here you get the sessile adenoma. Okay. Then there is again continuous microsatellite instability, accumulation of another mutation which regulate the gene growth like oncogene, tumor suppressor gene like TGF beta, BAX, apoptosis, activation of BRAF. This is also BAX and BRAF are the apoptosis gene, tissue growth factor beta is the growth factor oncogene. This will lead to development of the carcinoma over here. Okay, here also normal colon adenoma carcinoma. This is mismatch repair gene or microsatellite instability pathway. So pattern of sporadic and familial colorectal carcinoma. Familial, these are the hereditary and this is sporadic. Hereditary, you have two spectrum. Familial adenomatous polyposis. This is APC-WNT pathway involved genes are APC gene located on chromosome 5, hundreds of adenoma, adenocarcinoma. Hereditary non-polyposis colorectal cancer, involvement of DNA mismatch repair gene, MSH2, MSH6. See, in the hereditary, you have involvement of MSH2 and MSH6 gene, and it will lead to the adenoma and the mucinous adenocarcinoma. Here, just plain adenocarcinoma. Here, mucinous adenocarcinoma. While we go to the sporadic, same genes are involved. Majority of APC-WNT pathway, but here mutation in the somatic cell, not in the germline mutation. Okay, here you see the left side adenocarcinoma, while you have sporadic mismatch repair MLH1 gene, here the right side adenocarcinoma. Okay, understood this slide clearly?
Yes, doctor.
The same gene is involved in both. Okay, both in the hereditary and the sporadic. FAP adenoma, adenocarcinoma, DNA mismatch repair, MSH2, MSH6, adenoma, mucinous carcinoma, sporadic cancer. 80% of the time it is APC, left-sided adenocarcinoma. Same over here also. These familial adenomatous papulosis colon is more common than HNPCC. Okay. Here also it goes 85 to 80%. Here also it's 10%. Here also 80%, 10 to 15%. DNA mismatch repair. But here you see in the hereditary non-polyposis colon, MSH2, MSH6, while in the sporadic colon involving the DNA mismatch repair gene, MLH1. This is the high level questions which you can have in your SMLE or USMLE exams. Okay, so that's why I have included these over here. Okay, and the left sided adenocarcinoma, if you see, it's mostly due to the APC involved. Right sided mucinous carcinoma, mostly due to the DNA mismatch repair MLH1 gene. So colorectal carcinoma in the either hereditary and sporadic, 80% of the time this is mutation in APC gene, adenoma carcinoma pathway, further mutation in KRAS and P53 gene. 10 to 15% microsatellite instability or mismatch repair gene pathway, further mutation into the growth factor like tissue tumor growth factor beta or the apoptotic gene, BRAX, BRAF, okay, BAX and BRAF. So this is your in general, both in the hereditary and sporadic. And this is specific type of gene, hereditary MSH2, MSH6, right side mucinous carcinoma. Here MLH1 sporadic MMR gene, right sided mucinous carcinoma. So difference between FAP and HNPCC, it is like 100% risk by 35 years. Here risk is up to 80%. We get at least minimum 100, maximum you can have thousands of polyps at the colon. HNPCC, you have less than 10 polyps. That's why it is called non-polyposis. Less than 10 polyposis. So our case could be what? FAP or HNP?
H and B.
Yeah, it could be, but we cannot call it is purely HNP, because for HNP you need to have multiple involvement and specific genes. Okay, so FAP, you have mutation in APC gene, and there are like 5 gene, which you know over here: MSH2, MSH6 if it is hereditary, MLH1 if it is sporadic. FAP involved for 18 to 90% of the colon cancer. It is involved only 10 to 15% of the canon. Other cancer risk, you have duodenal and gastric. You have here other organs: ovarian, endometrial, and gastric. Now the risk categorization of the colorectal carcinoma. When do we call low risk cancer? One, first degree relative with CRC at more than 45 years of the age. If you have like a relative, first degree relative like brother, sister, mother, father, diagnosed at more than 45 years of the age, the person has low risk. Usually in the low risk, you don't have the screening at the earlier age, but you must aware your patient about he should notice any persistent alteration in the bowel habits, or anytime he see the blood in stool, immediately report. Okay. Low moderate risk, or low moderate risk we call it is okay. To first degree relative with CRC at average age of more than 60 years. You need to have screening in this case: one colonoscopy at 35 to 40 years of age, and one at 55 years of age. High moderate risk, one first degree relative with CRC less than 45 years of age, or three older first degree relative more than 50 years. Screening here, you should begin at 45 years or 5 years prior to the youngest. Suppose if someone has diagnosed at 45 years of age, the screening should start at the 40 years of age. Okay. Repeat 5 yearly up to 75 years of the age. How do you high risk? How, what is the preferred screening method in the high risk patient? It is the colonoscopy. Okay. In HNPCC, colonoscopies from 25 years continue 2 yearly up to 75 years of the age. Endometrial ovarian screening annually from 35 years. FAP, colonoscopy annually from teens. Okay. Here, 2 yearly, like every 2 years. Here, every year you have to do, and at the from the teens only. Okay. Like 13, 14, 15. Here you start little later. Okay. If you diagnose, you offer prophylactic cholecystectomy and upper GI scopy, usually do for the annually, usually because they have seen association of the gastric polyp and gastric carcinoma. So usually they do it, especially if you are interested in the research process. Okay, but you need always remember high screen, like high risk screening is always colonoscopy. Low risk screening, or in the high risk group, you do with the colonoscopy. In general population, you do with the fecal occult blood testing. Okay, these are the two important which I have not included in this slide, but I am telling you, remember, in high risk group, always colonoscopy. In general population, always fecal occult blood. Okay, because bleeding, the tumor causes bleeding, and the frank bleeding is not noticed. Generally, if a patient notice, he will report immediately, but occult blood is not seen by the patient. So you just do in a general population where you find there is more, like in the Medina, that the number one cancer is in the men is colorectal carcinoma. So you just offer every person after 50 years of, after 60 years of age, annually a fecal blood test. Now we go to the pathological features of the colorectal carcinoma. Adenoma and the carcinoma. Adenoma gross, you see it could be sessile, pedunculated. Okay, while in the gross, you see like either annular mass involving the entire circumference of the bowel, or exophytic, cauliflower, or ulcerated large polyphytic mass. Microscopy, you can have tubular adenoma, villus adenoma, tubular villus adenoma, serrated adenoma. Microscopic of the carcinoma, you have simple adenocarcinoma, mucinous carcinoma, signatory or mycoid carcinoma, squamous cell carcinoma. Adenocarcinoma, like tumor cell architecture, is the glandular. Mucinous, like in the tumors, is producing large amount of mucin inside and outside the malignant gland cells. So you see there is like pool of mucin in which the tumor cells are floating. Signatory carcinoma, usually here the tumor cell produce mucin which is predominantly inside the tumor cell, and these mucin push the nucleus at one side. So like the cell look like a ring where you have a diamond at a periphery as a nucleus and mucin in the cytoplasm look like a boundary of the ring. So that's called signet ring carcinoma. Squamous cell carcinoma usually seen in the anal region because of the lining. Morphology of in detail about the colorectal carcinoma. To save our time, we will discuss it later on in the lecture. Okay, practical session. So majority of the colorectal carcinoma seen in the rectum, rectosigmoid and the sigmoid colon, the distal part of the colon. Why distal part of the colon? The same mechanism, if you remember, the contact of the more formed stool, like the solidified stool remain for a longer period of the time in this part of the bowel. Okay, so that's why there is like more interaction between the toxic nutrients present in the stool with the epithelium. So there are high chances of cancer in this period. Left-sided carcinoma tend to be annular. Annular means it is the encircling lesion involving the entire lumen in the ring form. Okay, and that is seen in the left side. Why it is left side? Same reason, because the stool is more solidified. So, and there is the symptoms of obstruction because this annular region will constrict the lumen of the bowel, narrow the lumen of the bowel. So there is obstruction. Neoplasm always starts superficially. Okay, superficially in the mucosa, slowly invade the deeper layer with ulceration and eventually going outside the colon and to the different organs like liver, lymph nodes, bone, brain, and all those things. Okay, so this is a ulcerating mass. If I ask, it is which part of the bowel, which part of the large intestine? Can you answer me? Looking at this specimen, it is which part of the bowel? Large intestine. If it is in the large intestine, which part of the large intestine? Yes, which part of
In
the large
the
intestine? To make it easy for you, it is in the large intestine. Now tell me in which part?
in the flexure, right or left flexure.
No. Anyone else? Boys, I don't hear anyone, any boy's voice, any single voice. At least my group student. Yeah, cecum. Why it is cecum? Very good. Because you can see the ileum, ileocecum. Okay, it is in the cecum, the right side. So right side is morely ulcerated, large polypoidal ulcerated mass. Left side usually annular. Okay, this is like annular involving entire bowel. Okay, entire, like you see the ring. If you see, it is the open cut open bowel. So you see throughout the dimension of the bowel, and it present with the what? Obstruction. And you can also see some polyps over here, small polyps, 1, 2, 3, 4. So right-sided carcinoma tend to grow as a polypoidal, fungating, ulcerated mass. So obstruction here is uncommon, but bleeding is more common over here because there is ulceration. Invasion of the wall and extend to the mesentery, regional lymph nodes, and more distal sites can be seen in both right and left side because as the tumor grow, it goes from mucosa to submucosa to muscularis to serosa and can go to the lymph node or the distant organ. Mucinous adenocarcinoma secrete abundant mucin that may dissect through cleavage plane in the wall, because these mucin are more in number, so they can go normal cleavage planes in the wall, can go more easily into the walls, reach up to the serosa, and can come into the peritoneum and then cause mucinous ascites. Sometimes you can get the small cell or undifferentiated carcinomas. They usually very rare and seen from the neuroendocrine cells of the bowel. In ulcerative colitis, a poorly differentiated infiltrative adenocarcinoma with an exophytic ulcerated polypoidal growth can be seen, because in ulcerative colitis there are pseudopolyps. One of the polyps undergo into the dysplasia and can turn into the large tumor mass. Okay, so inflammatory bowel disease, ulcerative colitis is more common to develop carcinoma. Right-sided ulcerated mass, more bleeding. Left-sided annular mass, obstruction. So clinical feature of the colorectal carcinoma, usually like they are remain asymptomatic for, like any cancer, remain asymptomatic for a long period of time and then present with the full blown malignancy. Left sided lesion tend to present earlier. Why it is earlier? Because of the obstruction. But left sided lesion are infiltrative because they infiltrate deep. By the time they cause obstruction, they are already infiltrative. So they have alteration in the bowel habit, constipation, bleeding per rectum, loss of weight, lower and left iliac fossa, abdominal pain. Right-sided lesion tend to present with weakness, malaise, weight loss, unexplained anemia, because this remain for as a old age. Sometimes we say, okay, he is old age. That's why loss of weight is common in the old age. Weakness is common in the old age. Anemia also, but remember, any person, any elderly person coming with anemia, always look for the colon carcinoma and the gastric carcinoma. Okay. And as it is in the right side, so you might feel the mass or the right iliac fossa pain. So right colon, you have diarrhea, anemia. Left side colon, you have constipation, bleeding per rectum. If bleeding per rectum, okay. In the if the colon cancer in the rectum, one is the very important symptom is tenesmus. What do you mean by tenesmus? Pain while passing the mucus. Blood and mucus discharge also can be seen in the rectum. Okay, so this is the colorectal cancer clinical features. Spread of the colorectal carcinoma, it can be direct extension. Direct extension from mucosa, submucosa to the muscularis, muscularis to the serosa, serosa to the adjacent organs like urinary bladder, uterus in female. Okay. Metastasis through the lymph node or through the blood vessel. From the blood vessel, it usually goes to the, as it is the carcinoma, so lymph nodes will be the favorite site for it. While it is sarcoma, sarcoma usually go to the hematogenesis spread. But it can also go through the blood vessel and most common to the liver. Obviously, the drainage through the vein. It goes to the liver, but it can also goes to the lungs and the bones. And there is a one marker called as carcinoembryonic antigen. This is a tumor marker and it is related to the tumor size and extent of the spread. So when a person come with the view carcinoma and you do the CEA markers and it is the highly elevated. So you can suspect before the colonoscopy or before the opening the tumor can be large in size and there is higher chances of the spread. But usually carcinoembryologic antigen we don't use for as a diagnostic marker. They use for the prognostic marker. Very, very important prognostic marker, especially a person who has undergone surgical resection or chemotherapy for the colorectal carcinoma. So you see the carcinoembryologic antigen, follow up with the carcinoembryonic antigen. If this level is raised, you can suspect the recurrence of the tumor after resection. So it is a very, very important prognostic marker. Now coming to the staging of the tumor. We have two mechanisms of staging, British or European Duke and the American TNM staging. Okay. So like we go for the Duke. Duke stages are the A, B1, B2, C1, C2, D. What do you mean A? A, when the tumor is into the mucosa. B, tumor involve the muscle wall but not the completely. Okay, B1. The muscle, it has goes to the muscle, okay, submucosa and the muscle, but not the complete muscle involvement. B2, tumor has passed the muscularis and come to the serosa. C1, it is the B1, but local lymph node involves. So tumor involving the muscle wall, but not completely, but involvements of the local lymph nodes. C1. C2 is the B2 plus local lymph node. Tumor involve the serosa and the local lymph nodes. This is C2. And D is for distant mechanism. So A and D is very easy to remember. A is confined to mucosa, D is distant mechanism, metastasis. B1, it is passed beyond the mucosa up to the muscularis, but not completely. C1 as B1 plus local lymph node. B2, tumor involves the serosa. It has passed beyond the muscularis and goes to the serosa. If it is associated with the local lymph nodes, it becomes C2. Is it clear? Okay. So this is up to the mucosa. Okay. B1, B is like it has not gone, it has not talk about the B1 and B2. B2 is just, B is just like involving the muscularis and going to the lymph node. And C1, muscularis but not coming to the serosa, local lymph nodes. Okay. And C2, it's going beyond and the regional lymph nodes. Someone has the number of lymph nodes also. So we can go up to the B1, B2, C1, they call 1 to 4 regional lymph nodes and C2 more than regional lymph nodes. Okay. Anything like any B, any B2, any A. If like it is a submucosa, but 1 to 4 regional lymph nodes are involved, it becomes C1. If it is only into the mucosa, but more than 4 regional lymph nodes involved, it becomes C2. Okay. It doesn't matter with what is the stage of this. Okay. C1, it is like another way of classification. C1, 1 to 4 regional lymph nodes. C2, more than 4 regional lymph nodes. It is independent of these classification. Even D, even the tumor is limited to the mucosa, but you see the distant metastasis, it become D, Duke stage D. Case scenario has been presented to you. A patient has been diagnosed so and so, so and so. The biopsy shows the tumor well differentiated adenocarcinoma involving the mucosa and to submucosa, and no muscle is involved, no serosa is involved, but 5 regional lymph nodes positive for the malignancy. So what will be your Duke stage? A, B, C, D. Or if I say B1, B2, C1, C2, what will be your answer? I need answer. Okay, I repeat again. A patient with the history of colorectal carcinoma, biopsy is received. The pathologist has reported the tumor is restricted to the submucosa, no involvement of muscularis, and serosa is seen. Uh, but CT scan shows metastasis in the lung. What is the D stage? A, B, C, D. So what will be your answer over here?
D.
D. Yes. Now another same scenario. You have got involved tumor restricted to the tumor has invaded the muscularis but not completely, and 5 regional lymph nodes have been seen. What is your classification? B1, B2, C1, C2. What will be your answer over
C2.
here? C2. Yeah. Yes. Okay. So this is like that. And you see the survival 90 to 95% when it is in A, where it is in B1 90, B2 75% of the patients survive up to 5 years. When it is a C1 65, as soon as even one single lymph node increase, it becomes 42, and it goes wherever the tumor is located, even it is a submucosa or some small tumor, but it shows the distant metastasis. Survival is very, very poor. Now we go to the TNM staging, like American Joint Committee of the Cancer 8 edition, where you say that TX primary tumor cannot be assessed, T0 no evidence of the primary tumor, TIS carcinoma in situ or intramucosal carcinoma, only in the mucosa, not gone into the submucosa. Okay. T1 tumor invade the submucosa through the muscularis mucosa, but not into the muscularis propria. T2 tumor invades the muscularis propria. T3 tumor invades through the muscularis propria into the pericolorectal tissue. Okay. T4, like it goes to the adjacent organs like the bladder or the uterus. Okay. Visceral peritoneum T4A, T4B. No lymph node can be assessed. N0, no regional lymph node metastasis. N1, 1 to 3, N2, 4 or more. M0, no distant metastasis. M1, distant metastasis. So this is TIS only up to the mucosa, not gone to the muscularis mucosa. T1, just mucosa and submucosa. T2, up to the muscularis. T3, involving of the serosa. T4, going beyond the serosa, adjacent. N1, less than 4, less than or 3 lymph nodes. 4 or more lymph nodes, N2. So here, these are the stage 0. You have got TIS, N0, NM, tumor in situ, only into the mucosa, not going beyond. It is the earliest stage, and it can be like this is just restricted to the mucosa. Stage 1, T1, N0, N2, M0, T2, N0, N0. Stage 2A, 2B, like T3, T4, but N0, M0. Up to 2, you don't find any lymph node involvements. Stage 3, you get N1, stage 3B, N1, stage 3C, N2. Any T, N2. Whenever N2 comes, it becomes stage 3. And whenever M comes, it becomes stage 4. So stage 3 and stage 4 is very easy to do. Any T, any N, whether like to, it is TIS, but you see M1, it is stage 4. Okay. No lymph node, but M1, stage 4. If you see 4 or more lymph node involvement, stage 2, stage 3C. Okay. All these are the other stages. Okay. So you see, whenever stage 3 come, you have got the lymph node involvement. 3 or less, N1. More than 4 or more, N2. So this is classification for you. If you remember, it is well and good for you, especially for your clinical presentation and all those things. But at least remember this point. When it becomes stage 3C, N2. When it becomes stage 3, N1. Okay. Okay. Whenever lymph node come, stage 3. Okay. And whenever distant mechanism metastasis come, it becomes stage 4. Okay. What is the how do you diagnose a case of colorectal carcinoma? You have blood test, CBC, occult fecal blood analysis, especially screening in general population, colonoscopy, biopsy. Biopsy is the gold standard for the histopathological confirmation of the diagnosis of colorectal carcinoma, CAA for the prognosis, and obviously imaging for the staging. You need to do the ultrasound, CT abdomen, MRI, PET CT. This is for the staging. For the diagnosis, gold standard biopsy. All other tools are for the diagnosis. Treatment for goal, you can read it from the surgery. You must know what is colectomy, hemicolectomy, subtotal colectomy. Okay. And adjuvant chemotherapy, adjuvant, neoadjuvant, targeted chemotherapy. And this is, we finish our lecture. Sorry, taking 5 minutes extra from you. I hope it is clear for you. If you have any doubt, please feel free to contact me anytime. Okay.
Okay, thank you, doctor.
Thank you all. Okay. Jazakallah khair.